Hello, everyone. On behalf of York Hospital, I'd like to welcome you all today to our Zoom webinar, What's Going On Down There? All Your Women's Health Questions Answered. Our presenter this afternoon will be Dr. Sarah Jean Hansen, one of our physicians at OBGYN, Surgical and Midwifery Associates of York Hospital. So following the success of her live event, where she offered the same information last August at the York Public Library, we hoped to spread the word to even more women. And Dr. Hansen graciously agreed to an encore virtual performance. From perimenopause to pelvic prolapse, she's got you covered. So before Dr. Hansen does take the stage, we have a few quick housekeeping notes to review. She will present for approximately 40 to 45 minutes, followed by a question and answer session. But unlike traditional Zoom, where you're able to see everybody's faces throughout the meeting, during this webinar, you will only see Dr. Hansen along with her current slide. And as participants, your audio has been muted. So if you do have a question, you can type it into the Q&A button located at the bottom of your screen. We'd prefer that you avoid using the chat or raise hand icons, as those will not be monitored as closely during the presentation. If you have a question that hasn't been answered during our time together, please feel free to email us at info@yorkhospital.com, and we'll be happy to send along a reply following the meeting. And lastly, this webinar is also being recorded and will be available to you along with everyone in the community next week on York Hospital's YouTube channel. So now, once again, thank you very much for tuning in today and spending this time with us. We hope you find the information helpful. And now we're pleased to go ahead and get started as we turn the program over to Dr. Sarah Hansen.
Thank you. Hi, guys. Thank you for joining me. I wish I could see you in person. Oh, you already beat my punchline on the slides. This is why I got to do my own slides. So I was going to share, my background is a lot of global travel. And so I said, I was going to say the presentation here will be talking about what's up down under. Now you can hit the next. And then I was going to talk about my trip to Australia. Not really. Just talking about women's health issues in general. I think, I love taking care of women as patients because we're complex and interesting people, and from adolescence to menopause, there's so many things to discuss, but something that maybe we don't discuss enough with our families or in school. And so, I hope that this can be a moment that I can help kind of answer some questions as best I can. If I can't answer them, to try to look them up, and in the future maybe have more discussion around these topics. So I can take next slide, please. So today I am going to focus my talk more on perimenopause and menopause. And certainly there's a breadth of things beyond that as well, but this talk will be specifically around those topics that I've prepared. But if you have questions that are outside of those, then certainly ask them and I can get to those at the end. I'm going to talk specifically about, pelvic floor and bladder health, talk about sexuality and wellness, especially around menopause and perimenopause, and then answer any questions that you guys have. You can have the next slide. So I have no financial disclosures. So I do this just because I enjoy it. No drugs that I mention or procedures that I mention, I have any stake in those companies. Okay, next. So I worked for many years with indigenous communities. So I worked overseas and then also in the US with the Navajo Nation and in Alaska. And, in those cultures, women who are elders in those communities are really revered. There's a lot of respect for elders. I think that that's something in Western culture that sometimes we're lacking a bit of. And in those cultures, older women are referred to as wise women. So I will take some questions, that many of my wise women have asked me, and I'll put them here and ask yourself if you have these questions too. And they're things that I'll talk about in my talk today. This is the wise woman in my family. This is my mom with one of my kids, my youngest of my three. my little 2-year-old. So the questions that I get from my kind of wise women who are the perimenopausal and menopausal patients that I see is, should I have my hormones checked? Like, what are my hormones doing? Are natural hormones safer? So should I take hormones after my body stops making them? And if so, should I take natural ones? Are they going to be better for me? What can I do to help myself stay healthy in menopause? That's a common question that I get from women. For women who are perimenopausal, kind of in that pre-menopause phase that are still getting some periods, they want to know, what are the treatments for their weird periods or their heavier periods in that transition time. One question that I get a lot is, what can I do to help my bladder, to make my bladder stronger? And can I do any exercises, and what are those? And then, is surgical bladder mesh safe? We'll talk about that and what that is. And for women who are in menopause and perimenopause, what can I do to make intimacy, so my sexual life, more comfortable? So those are some things I'll address in my talk. Okay, next slide. So I'll define things first. Menopause and perimenopause. So the kind of dictionary clinical definition of menopause is when you've had no period for a year. So that is when your ovaries are stopping producing hormones. It's a natural process. This happens to all of us at some point. The ovaries produce estrogen, progesterone, and testosterone, a small amount, but primarily estrogen is the hormone that we notice symptoms from the most, both when they're there and when they're not. Perimenopause is also basically pre-menopause. So it's the time before you go through menopause. This is going to be when your periods are more irregular. For many women, they might be heavier. And this, for some women, is very short. It may be a couple years. And for other women, it may last a decade. That's very individual to the woman. This process may start somewhere, for most women, in their 40s sometime. And the average age to being complete, so no periods at all, is going to be around age 51 in the US, population dependent. So around 51 is going to be average. Now, I have patients at 45 who are in menopause, and that's not considered premature. And I have women at 55 who are still getting periods monthly. They're not going to be able to get pregnant above 50, even if you're regularly ovulating, or excuse me, if you are occasionally ovulating and having regular periods. The quality of eggs is low enough that pregnancy is not possible above 50. So we don't need to worry about birth control, but certainly many of those women still will be having periods. So this is a natural process. We all go through it. But just because it's natural doesn't mean that it isn't very symptomatic for many women. Many women really suffer during this time frame. Patients will say, like, when am I done with menopause? And the answer actually is when you're dead, because menopause is actually when your periods stop, and that's the rest of our lives after that. So, that's a large portion of many of our lives. So I think it makes sense to devote some more time on kind of thinking about perimenopause and menopause and how we can feel better and be healthier during that time frame of our lives, and not just think, gosh, what's wrong with my hormones? Next slide. So many women who have gone through or are going through perimenopause or menopause can tell you, and if I was in a lecture where we could all see you guys, I'd have you guys raise your hands if you're having any of these symptoms or had them. And they are the neuroendocrine system, your brain connected to your reproductive organs, right? But as we know, these symptoms affect our whole body. So the common symptoms that women are going to feel around menopause and the menopause transition are going to be impacting every one of the organ systems of our body. So from really neurologic symptoms, patients will notice hot flashes, right? So some patients get this just as the sweating. Other patients get it almost feeling like it's like a panic attack. This is because of impact of menopause and the hormone changes on our hypothalamus, which is the temperature regulator of our brain, but it's also the organ that helps to regulate the pituitary gland and our ovaries in our body. Because of this, also these changes in our hormonal levels as produced by our ovaries, our sleep gets impacted too. And again, that's from within our brain. For some women, it leads to depression and anxiety, these mood symptoms. Women who've had a history of depression and anxiety have an increased risk of worsening of those symptoms when they go through perimenopause or menopause. But sometimes some of the other symptoms, so having the hot flashes, having the impact of sleep, can lead to some of these anxiety and depression symptoms as well. Some women will say what is called, like if you internet look it up, will say that they have brain fog. So they may feel that they are more foggy, their memory isn't good, and then they have some cognitive changes. Um, Statistically, women who are tested, so take tests for memory or cognition or how well they can solve problems, they do just as well if they're in menopause or before menopause and compared to men. But they may feel that they notice that they answer those questions differently for them. So the answer is yes, it impacts us, but we compensate for it. So although we feel different, it's something that doesn't impact us to a point that it can be tested. Does that make sense? And then also some women will notice that their headaches change and they may get more or fewer, more or less migraines related to menopause. Their skin will change. So estrogen helps to make our skin have more elasticity and hydration. So we might notice that our skin and hair changes around menopause. Because of that small amount of testosterone made by the ovaries, the sex drive or libido can decrease around menopause. But some of that also is because of the changes of the tissues there, that they're thinned. Because of the change of our hormones being from female predominated hormones to those being gone, our body weight distribution will change. So people will gain weight because their metabolism will slow down somewhat. And some women will gain a little bit more weight in the central part of their body, around their stomach or their belly, which is less common of a place where women gain weight if their hormones are normal during reproductive years. Instead of in hips or maybe shoulders, where women may put a little bit of weight, when they change in weight, they'll put it more in the middle of their body. And then certainly noticing changes to the bladder and the vagina, sexual function, those are related in many ways to the changes of estrogen. And then some women will notice that they have more pain in their joints, and they lose some muscle mass. And some of that's hormone related as well. We definitely know that it affects our bones. As we lose estrogen, that our bones will thin. So really menopause affects our whole body. It's a massive change for our entire system. Okay, next slide. Pre-menopause is what becomes right before menopause. So this is when women are going to get more irregular and more heavy periods. They're heavier because those ovulations may not be as normal. This actually happens to girls when they're going through, when they first start their period, what's called menarche. And that's because that signal between the brain and the ovary, that male, those messages are not getting through as clearly because the ovaries are still kind of starting up. Well, the same thing happens at the end of our menstrual cycles. As those messages aren't getting as clearly through, women will get more irregular and heavy bleeding. So no, there's no one that I see that says their periods are better when they're in their 40s or early 50s. They always are worsening. But this is something that we need to, certainly see your doctor about. Although it's normal, there can be problems, right? So that we need to screen to make sure that there isn't a precancer that's present of the cervix or the uterus, because those are things that can cause irregular bleeding. Hormonal problems like your thyroid being out of alignment, which is common in women who are postmenopausal, and women in general, we have more thyroid problems. We need to ensure that those medical things are taken care of. So if you have that irregular bleeding in your 40s, or someone in the family who's going through this, it may be very normal, but it's something you still need to see your GYN doc or your PCP about, because we need to make sure that we rule out those other things. Make sure you're up to date with all that other routine screening to make sure, yep, this is indeed perimenopause, or, oh, there's something, something we need to address from the lining of the uterus or from the cervix. So as long as we address that all those things are normal, then this is very treatable. So I won't go into a lot of details about this. If people have questions at the end, I'm certainly happy to answer them. But we have, my grandmother's only option when she had heavy bleeding would be to get a hysterectomy and have her uterus removed. Now we have other options. So we can place a progesterone releasing device called an IUD into the uterus. It's a tiny little plastic T that is placed in the office. It's easy placement in and out. Patients do really well with it. And we could perform an endometrial ablation, which is burning the lining of the uterus. And that's an outpatient surgical procedure that really requires no downtime and is about 90% effective for decreasing or stopping bleeding, or take a uterus out. And the way that we do that is going to be minimally invasively the vast majority of the time. So 90% of the time or more, we can take the uterus out usually using either laparoscopy, small lighted camera instruments, and other laparoscopic tools like the robot, or vaginal hysterectomy, which is the most minimally invasive. So we just take the uterus out through the vagina with no incisions. And so people can go home the same day from those, or just stay overnight in the hospital. So Certainly, even if a patient needs a hysterectomy, it's not the end of the world. And we would take the uterus out usually alone and leave ovaries in, because although they're maybe not making as much hormone, they're making still some. We often remove the fallopian tubes at the same time because that decreases risk of ovarian cancer, which is a rare cancer, 1 in 70 lifetime risk, versus breast, which is much, much more common, but can be a very aggressive and challenging to treat cancer. So we can remove the fallopian tubes to reduce that risk if a woman does require a hysterectomy ultimately. Next slide. So one of the common questions that I have for my patients is about hormone replacement therapy. The hormones that we replace in hormone replacement therapy are going to mainly be estrogen. And so the estrogen is what's going to help the vast majority of the symptoms that patients talk about. Problems with sleep, hot flashes, the estrogen helps them feel better. If you have a uterus, then we would give you progesterone as well, because if we gave you estrogen alone, that could cause a precancer or overgrowth of the uterus to occur, and could lead to endometrial cancer. That risk is not there if we give you progesterone. So if your uterus is still present, we'll give you that hormone as well. The progesterone alone doesn't provide a lot of benefit for those hot flashes, though, but is possible. Some patients do take a small amount of testosterone hormone replacement therapy, and this can help a little bit with libido or sex drive. It does have some other side effects and can impact our lipids, cholesterol, things like that, and does have to be monitored pretty closely, but occasionally we replace that as well. So we can replace this in all different ways. So we can give patients a pill to take, just like birth control pill, but it's a much lower dose of these hormones. There are patches that are look like small, like little Band-Aids that most commonly are worn like 1-2 a week. We can use creams. There are also ways that patients can get implanted hormones, something called pellets. And then vaginally, we can fix those vaginal symptoms alone with either a cream or a ring that is placed in the vagina. Next slide, please. So is hormone replacement therapy safe? This is what many of my patients want to know. And so any of you guys that I may have seen as a patient or anybody in the future, the study that I talk about that's most helpful for us with advising women about the safety of hormone replacement therapy, or HRT, is the Women's Health Initiative study. So there were thousands of women enrolled in this study, and all of the women were given hormone replacement therapy. They were studied for outcomes. Ideally, the idea was, women who, we know that women who go through menopause earlier may be at risk for Alzheimer's or dementia, higher than women who go through this at a later date. And we know that women who go through menopause earlier may have higher risk of coronary disease or heart disease. So in this study, all the women in the study were placed on hormone replacement therapy in order to look at outcomes like bone density and hot flashes, side effects like that we know are helped by estrogen, but also these other outcomes. The study was actually stopped early because it showed what we already knew, though, that estrogen increases risk of blood clotting, but it did not show an improved benefit for the patients for decrease in dementia or Alzheimer's or heart or decreasing heart disease. So what we found out from the study is that hormone replacement therapy helps a lot with hot flashes. And I will tell you that from my own empiric evidence, basically my practice of taking care of women now for 15 years or more now in practice, is that estrogen helps hot flashes immensely and better than anything else. Individual women may have other benefits, though. Some women will notice that they do feel like their memory is better, that their energy is better, that they feel better in general. But that is not really replicatable in big studies, and I can't generalize that to all patients. We do know that risks are rare, but they could be serious. So it does double a patient's risk of having a stroke, for example, of being on estrogen and replacement hormone therapy. We take that seriously. And so that's something to consider when taking the hormone replacement therapy, but it is a rare risk. So although it doubles a rare risk. So the vast majority of women, thousands of women who are on hormone replacement therapy, will not have complications such as a stroke. So we try to give the patient, and this is dose dependent. So the higher doses increase risk more. So we try to give patients the lowest possible dose that fixes their symptoms for the shortest period of time. Now, that may be that women who are above 60, which we know is a higher risk patient profile for a stroke, that they still need to be on the same dose that they were on when they were 50 because they don't feel good unless they're on that hormone replacement. So we just take it really patient to patient. In the end, I tell patients it's not a medication without risks, but it's not overtly dangerous, and it's just something we need to check in about every year to decide if you're on the right dose, if we need to decrease it a little, and when starting it, if we need to increase it a little bit to see if we get you more improvement. Um, so patients will ask about, natural hormones or bioidentical hormones. Those have been studied and certainly may improve the hot flashes just as well as synthetic hormones that are created in the lab. There's not as much data for them. So just because something is natural doesn't mean that it's safer or less safe. It may or may not be. Um, we don't have any data to show or evidence basically for me to advise patients that it's safer to take a bioidentical hormone. There's no reason to think any scientific evidence that it reduces risk of stroke to take bioidenticals. So they still have the same risk. And we are not certain that we can advise patients to take bioidenticals that it will work better. The best studies kind of around compounded or bioidentical hormones show that if they have the right amount in them, that they can be very effective or equally effective. The problem with compounding is it can be variable. So there may not be a standard of a dose that a patient gets with bioidentical hormones. But many patients will choose to elect to take those as well. And we monitor those symptoms and side effects the same way as we would with patients who are on synthetic hormones. Next slide. So if, let's say you don't want to take medication for it. And I don't know, I think I may have another slide that's coming too. So we'll talk about that in a minute. There's been good evidence that shows that women who are on a Mediterranean diet, that is a diet that is really full of primarily plant-based whole food, healthy diet with a little bit of lean protein, that those women do better in menopause. They have fewer hot flashes and they feel better. This is also a diet that's really heart healthy and has been known to improve patients with, heart disease history. It's good for hypertension and good for cholesterol. So this is a great diet for us in general. There's a lot of phytoestrogens or plant-based natural low-level estrogens that occur in this kind of a diet just naturally in the plants. So it doesn't require taking any supplements or anything like that. That's not necessary because you get those things in these foods and they have the added benefits of all those things that are in healthy Mediterranean diet. So that's a thing that I recommend to patients, is to try to switch to this kind of diet if possible. We know that patients who stay active, who exercise more, do well and do better in their hormone, in their transition than women who are less active. And we know that women who generally address their wellness, which we'll kind of talk about as well, do better in their menopause transition. It wasn't on my last slide, but there are some other medications that we can prescribe that can help with hot flashes that are not hormonal. If you have blood pressure issues, there's a blood pressure medication that will also help with hot flashes that is non-hormonal that we prescribe for hot flashes in some patients. And there is an antidepressant that we can prescribe at a low dose that helps with hot flashes as well. So if a patient also has a mood disorder, that can be something that we can treat two things with one. And so those are a couple other alternatives to think about if you have some low-level depression and anxiety and also hot flashes and would like to avoid estrogen. We can prescribe one of those antidepressant medications. And if you have a blood pressure issue and also have hot flashes, we could prescribe one of those blood pressure medications. All right, next slide. So what are the exercises that we should be doing in general as women, but particularly perimenopausal like myself or menopausal ladies? So cardio exercises. So sweating every day, so doing something where you get a sweat working up, has shown to decrease hot flashes for patients. And that makes sense. It's kind of like gets it out of your system a little bit, right? Working on our core strength. So things like Pilates, Yoga teach this very well. There's a Pilates and yoga move here that is called the bridge, which is a really or like a pelvic tilt kind of exercise. The reason why that is a really great exercise to do daily if you can. Core strengthening is good for us, not just for our pelvic floor to help strengthen it, but also for our posture, keeping our stomach like looking flatter, and sort of cosmetic stuff as we maybe gain weight differently as we age and our metabolism changes, but also helps with back pain and posture. So core strengthening is important for all those things just functionally in our life. So Kegel exercises, my mom taught me to do Kegels at the red lights. Other people have told me to do Kegels in the line at the grocery store. Do them whenever you can. Patients will tell me, I did some Kegels and they didn't help. And I asked them how often, and they said they did them like once last month. Well, if you went to the gym once in a month, you wouldn't get fit either. So it's something where you have to do the exercises regularly and concertedly in a good way to find benefit from them. Pelvic floor physical therapists have taught me some specifics of Kegel exercises that I'll share with you guys. The Kegel that we're taught, or kind of exercise of the pelvic floor, is to use that muscle that sort of stops the flow of urine and to try to hold that muscle up or tighten it. If you practice, there's 3 different kind of Kegels you can practice, but certainly we can make a referral to physical therapy to teach these more specifically, and think of that as being like a trainer at the gym. Well, this is a trainer for your pelvic floor, but I'll give you a little like briefer. So you can try them all now. In fact, I'll encourage you to do it. Why not? You're here in the sexual health class, right? So the first one is take that muscle that stops the flow of urine and squeeze it and hold it in. So keep trying to breathe or talk normally with that muscle held in. I'm doing it right now with you. And try to hold it for a good 10 seconds at least. And then when you're done with that 10 seconds, let it relax. Then do it again, and then repeat this at a few times at an interval. If you can work up to 20 seconds that you hold it, it's even better. The second exercise that you want to do, I call them reps. So you want to pull that muscle in, tighten it up as best as you can, and then relax it. Pull it in, and then relax it. And you practice that multiple repetitions of that, 20 at least in a row, a few times. The final one's the hardest one, but the best ones are sort of like retraining both your pelvic floor and your core strength. So you're going to start behind that muscle. The muscle's kind of around the anal sphincter, so where our stool comes out. So you want to kind of, as my kids would say, squinch your butt. So you want to kind of pull those kind of butt muscles together in the back. Next, you're going to want to, that's like the bottom floor, imagine, if you're riding an elevator. Now you're going to go to the second floor. You want to kind of tighten and squeeze the vaginal muscles. So we've got both of those muscles squeezed now. Now we're going to go up to the third floor. Tighten and squeeze those urethra muscles, the stopping the flow of pee muscles, that traditional Kegel. Now you're going to go all the way up to the fourth floor. You're going to take your muscles around your belly button or your lower abdomen and tuck those in towards your spine. They teach this really well in yoga and Pilates and ballet class. I used to learn it when I was a little kid. Tuck that all in. Now you're going to relax your belly button muscle, urethra muscle, vaginal muscle, rectal muscle. It's hard. Mine kind of fall apart there at the end after I had 3 C-sections. All those muscles are a little messed up, but practicing that really helps our pelvic floor. So that's an example of doing really good Kegels. All right, next slide. So as a woman, our bladder is built for continence, so we don't pee on ourselves like a watering can. We have an angle. So as we have time, gravity, age, and babies, we lose that angle. So with weight, chronic coughing, constipation, these are things that can make this angle straighten out, right? And so then if you cough or sneeze, when you put pressure, then you'll leak. And that's what's called stress incontinence. If we strengthen those pelvic floor muscles, we retain this angle of our pelvic floor. So we do that by maintaining a healthy weight, eating fiber so we don't get constipated. This is dietary fiber just in our food, but also can be supplemented. Things like quitting smoking will help because it makes the tissues healthier there because they get better blood flow, but also then you're not coughing frequently. And just generally getting good nutrition so that these muscles are staying healthy and the proteins are getting to them, and doing these Kegel exercises like we talked about. Another thing that helps significantly is vaginal estrogen cream, which is a hormone replacement therapy that doesn't go through the whole body. It's just in the vagina. And that cream will help the tissues to respond and have better elasticity and strength that will help our pelvic floor as well. Next slide. So Pelvic prolapse or relaxation of those pelvic muscles is basically the idea of like a hernia in the pelvis. So if you look in this picture, the kind of area in the middle is our uterus. That's that kind of circular, kind of semicircular, that's the womb area in the middle, the little fallopian tube ovaries next to it. If you go down from that, you see the vagina. Behind it, so to the kind of to the left hand side of the screen, is going to be the rectum. So that's going to end at the anal sphincter. That's where stool passes, or when we go to the bathroom and we have a bowel movement. In the front is the bladder. And as you can see, the bladder and the rectum are right next to the vagina, but they have the separation of them in this picture. If we lose that separation, if those muscles relax or even bust open some of the connections with having a baby, for example, or gaining a lot of weight, or just for some people, this just happens, it's relaxation of their tissues just genetically, then we can get like a hernia and the bladder can kind of fall down into the vagina. That's what's called a cystocele. The rectum can kind of pooch or push into the vagina, and that's called a rectocele. We can treat these by exercising and improving some of our pelvic floor strength, but by placing a rubber ring called a pessary, which really looks like a diaphragm. If any of you guys ever used a diaphragm for contraception, it's similar. It's a little smaller, it's a little more flexible, so it's even more comfortable than a diaphragm. I find that women really do well with these. Some patients, I put a teeny tiny one in them and they're uncomfortable, and I call those my princesses in the pea, like the story of the princess in the pea, where there's a tiny pea and she was sleeping, on 50 mattresses and she could feel it. There's a few of you that are aristocracy and won't do well with a pessary, but for the rest of us, and that's most of us, a really even large pessary will not be felt by most patients. The most common size of a pessary that I put in a patient is going to be about this big. So it's going to be about the size, like here's my little yogurt container. It's going to be smaller than the circle of this yogurt. So about three or 4 centimeters across. They're rubber and flexible, and it basically makes a splint. So you pinch it in half, put it inside, it holds up the pelvic organs. You can go about your life, normal activities. If you would like, you can put this in just if you're doing something where you're straining, you're working in the garden, you're going on a long hike, and then take it in and out as you wish. You can be sexually active with it in place, just like a diaphragm, or you can take it out. That's up to you. Other women will prefer to leave the pessary in all the time and then have us take it in and out in the office. You can safely do that and leave it in for 3 to 6 months at a time, and if so that you don't have to take it in and out. When you get to those kind of 3 to 6 months kind of time frame, you may have more vaginal discharge. So that may be a reason we need to switch it a little bit sooner, but women really tolerate this well. Let's say you don't, tried pelvic floor exercises, you tried the pessary and it's not working for you. Well, then we would do surgery to help repair these these prolapse areas. So the way that the surgery is done is by putting stitches underneath the bladder, under the vagina, like a corset. We tuck it back in. We use your own tissues to sew that back up. We usually take the uterus out because it's kind of in the way. We resuspend the uterus to the muscles that are in the ligaments that are deep in the pelvis with some stitches. And then behind the vagina above the rectum, we put those corset stitches in again. It takes us a couple hours to do this pelvic floor repair. It's like a little reconstruction in there. It's all done vaginally. And then usually overnight in the hospital for 1 night. You need to really take it easy for a couple weeks when you go home, and then you can resume some normal activities except straining or heavy lifting for about 6 weeks. And then this will be a cure for patients of their pelvic prolapse. Patients do really well with these surgeries, but sometimes they could have risks like bleeding or infection, although those are rare. There could be a recurrence of the prolapse at a later date. That doesn't happen for most women, but could occur, especially if you gained a lot of weight or weren't able to keep those 6 weeks for everything to heal really well. Those would be reasons why you might recur, or patients that are smokers. And then the final thing would be that for some patients, they may end up getting some pain in the area of the surgery, although that's uncommon as well and usually just short-lived. People generally love these repairs and consider them almost life-changing. For patients who aren't sexually active, we can actually put stitches to sew the vagina closed. It's something called a colpoclesis surgery. For patients who aren't sexually active anymore, this fixes those prolapse areas with an operation that takes under an hour, and we can do it under local anesthesia in the operating room and go home the same day. Shorter recovery, and patients do really well with that if they no longer want to retain sexual activity. So it's less of a big repair, but if you need a permanent fix, that'll do it. We can also repair those areas with a surgical mesh that's generally done robotically. Most patients do really well with that repair, but there are some risks of placement of mesh, like that it could erode into the bladder or the bowel. And so those are things to consider if you elect to do some mesh placed there to help to hold things in place. If you're interested in that kind of surgery, I can always talk to you about it, and we refer people out for that. Next slide. So stress incontinence is when you cough or sneeze and you leak. Remember the watering can kind of analogy? This is very common, but it's not normal. I say that meaning that I have patients who stop playing with their kids because when they're running around playing with their kids, they leak. They stop exercising because they leak. It really impacts their life. We can fix this very easily if the Kegels don't improve it or losing weight doesn't improve it by putting in a little bladder sling or tape. This is an outpatient surgery that takes me under an hour to do. Again, you need some recovery after, not a little soreness for a few days to a couple of weeks, but about 6 weeks of not doing heavy lifting. So that sling goes back to the perfect space and stays there. It keeps that watering can angle back there because it tucks it back up. So you can see it as the blue thing in these pictures of where we sort of put that tape. My partner, Bob Cervenka, and I have done hundreds and hundreds of these. The one on the right is the type he does, TOT, and I do the one on the left. They both work well. It's very effective. It is considered permanent. So we would want to implant this in patients who were healthy and had quit smoking and their diet was really good, because we don't want them, there's no way to really take that out. It's in there, but really the recovery instructions are the most important for success, just not straining on that sling. But this is incredibly well tolerated by patients. It's life-changing. When I do probably want a couple of these slings a month. When I see the patients back in the office, they always say the same thing. This changed my life. I love this operation. Okay, next slide. Oh, I lost my picture. I had a picture of my puppy here. You can go back. Urge incontinence is when you feel like that I gotta go right now feeling, where you can't quite make it to the bathroom. So this is common but different than stress incontinence. The urgency incontinence will come often for women. Number one, because of bladder irritants, the most common being alcohol and caffeine. So that's the first thing I tell people. You got to back off on both of those things. Having the thinning of the tissues of the vulva and the vagina, which can occur after having a baby, but can also happen around perimenopause or menopause, is another reason why patients will have more urgency or urge incontinence. Other medical conditions can cause it too. So having diabetes or something like that can cause the bladder to basically have spasms that tell you to go to the bathroom when you don't need to. The way that we do this is have you avoid those bladder irritants to treat this. We can prescribe medications that will help your bladder to send you the right message that you need to pee, not the wrong message. And then we retrain your bladder like a toddler or a puppy. So what do you do when you have a toddler you're potty training? You take them to the bathroom, you have them sit on the little potty and just try to go to the bathroom, even if they don't need to, every couple hours. And then you reward them, you say, good job. And then you say, well, let's try one more time. And then if they do it, then you're like, okay, good job. And then you space it out to 2 hours. Then you do that every 3 hours, and then you retrain your bladder. Same way with a puppy, right? Like take them out, have them just try to pee every couple hours. Well, it's the same thing with bladder retraining. When you have urgency incontinence, you pee when you can't quite make it to the bathroom, we retrain you. Stop having as much caffeine, don't have alcohol or a lot of fluids in the evening. Go to the bathroom every couple hours, during the day, take the medication that helps the bladder to be less irritable. And then slowly we can space out how often you go to the bathroom and try to go to the bathroom every 4 hours, then 6 hours. And then we get you to a more normal bladder pattern. Next slide. So, there are anticipated changes that happen with our sexual health with aging. So, because the tissues change, there's going to be less lubrication that's produced by the vagina. There's some thinning of the tissues where they're already very sensitive and they become even more delicate. And then things are going to get atrophied or smaller and more sensitive because of that. And then patients may just in general have a little less energy or libido. But there might be good things that I notice from some patients. They'll say, my sexual relationship is more mature with my partner. We can communicate better about what we enjoy with each other. We have more time for it now that our kids are out of the house. We have, we don't feel that like there's the pressure that we like need to go take care of them, or someone could come in the room. They can like be more spontaneous maybe. And before, when you've gone through menopause, there's no pregnancy concern, and for some patients that actually makes sexual relationship more enjoyable. I will say, don't forget there's other medical conditions that can also contribute to sexual function issues. So make sure you talk with me or your primary care doctor about that, and make sure we treat those conditions if they're present. There are some things that require a steroid cream or other medical conditions that might be going on. And just because someone is menopausal doesn't mean that they couldn't be at risk for sexually transmitted infections. We want to make sure that if you have a new partner that we do address that. Next slide. Or excuse me, next slide. Thank you. So the thing that, I like to recommend for patients who maintain sexual activity or just comfort of the vulvar tissues once we get into menopause are a couple different things. First is a vaginal estrogen cream. So it's estrogen that just like what we put in hormone replacement therapy, but it doesn't go through your whole body. It won't help you at all with your hot flashes, but it also doesn't have any risk. This cream we place in, it comes in a little tube, and you want to put some on your finger, like a toothpaste on the toothbrush, like that amount, and put it on those external vulvar tissues, but then a little bit inside the vagina as well. And do that every night for a couple weeks. And then after that, as often as you need it. That's really individual to the woman for all of this. Some women need to put lotion on every day on their skin. Some women have to use more in the winter. Other people need less. And it's similar with these estrogen creams or vaginal lubrication. Some women may need to use a little more. Some women may need to use a little less, but most people need to do some of these things as they continue sexual activity, but also just comforting these tissues with aging. The only downside really with the estrogen cream, it's a little messy, sloppy is what one of my patients said about it. So I generally tell patients to use it at night. There are some little pills or suppositories that we can use instead of a cream too, if you prefer that. And a ring also that we could use if you are doing well, but don't like the cream element. The really only negative of all of these is they can be quite expensive, even with insurance. And I have nothing to say about that, except that I do women's health, and women's health is not covered as well as it should be by insurance or reasonably by drug companies. Using a lubrication for sexual activity is really important. You can get an over-the-counter water-based or silicone lubricant. Those work great. You can also use stuff that's in your cabinet. So many patients like coconut oil or olive oil. Some patients like that the coconut oil smells and tastes good too, and kind of make fun out of using it. I would say just because something's natural doesn't mean that it's not necessarily going to be harmful to you. So just make sure that you take some of that and you try it on a small part of your body first to make sure you don't have a reaction to it. And basically, like any sexual relationship, just keep active, keep being creative and communicate, and I have many patients who maintain functional sexual relationships well into menopause. So next slide, please. So, one of my kids was asking me about something, and we looked up orcas and read about how orcas have grandmothering as a really important part of their social structure. And it got me thinking about what other mammals or animals go through menopause, basically have a huge portion of our life that we're living past reproduction. This is unusual. Like most animals, as soon as we stop being able to have babies, that's the end of their life. But there's a few of us, humans, orcas, gorillas, elephants, that have something in common, that we all have menopause. New line or new slide, please. And it's because we do grandmothering. So elephants can live well into their late 60s, and they serve a function the same way that grandmothers do, wise women do, and that's in helping moms, helping the babies, sharing knowledge, doing grandmothering, basically. So I guess I want to end that talk thinking about the importance of being a wise woman of our menopausal years, and knowing that it's not our senescence, but it's actually a huge portion of our life that there's a very important function to. Next slide. So this makes sense that women who stay active, stay engaged, and stay positive do better in menopause. They're healthier, they live longer, and they feel better because their wellness in menopause is equal to their wellness in life. And that doesn't necessarily mean actual grandmothering of grandchildren if that's not in your life. It could be staying engaged in your work, in your community. It could be your grand dog, like this mom in this picture, right? But that does seem to, really bring health to our menopausal ladies. So next slide, please. So to answer a couple of the questions from the beginning, should you have your hormones checked? Patients ask me this all the time, and the answer is No, we need to make sure that your thyroid is normal. So we should check that. And you should make sure your vitamin D is okay, especially that we live kind of in a colder northern climate where we get less of that in the winter. I used to live in Alaska. We had little light boxes on our desks to make sure that we got enough of that in the winter. You want to make sure that you don't have depression. You want to treat underlying illnesses, but no, we don't need to check your hormone levels. If you're going through perimenopause or you're in menopause, your levels are low. We know that. And we're not treating a level, we're treating how you feel. So if you don't feel well, then we treat your feelings, not your hormone level. Are natural hormones safer? Sadly, no. So bioidenticals have not been proven to have less risk of stroke or other complications or cancer than synthetic hormones. What can I do to stay healthy in menopause? So make sure you follow up with your primary care doctor or GYN. Get your mammogram every year, eat a healthy, whole food, primarily plant-based diet, stay active, reduce stress, get enough sleep and get outside. Make sure you get your pap smears. Those stop at 65. We don't need to keep screening them unless you're in a unique circumstance because you no longer have risk factors for cervix cancer because it's virally sexually transmitted. And beyond 65, patients shouldn't generally have a risk for that. You're going to see, your OBGYN annually to make sure you get a pelvic exam. Certainly see us sooner if you have bleeding or other concerns. So those are things to do when you're in menopause. Next slide. What are safe treatments for irregular periods leading up to menopause? So we could put in a Mirena IUD, one of those little implants in, we could burn the lining of the uterus and do an ablation, or take the uterus out, do a minimally invasive hysterectomy. So you just see us in the doc to make sure that we're ruling out any other medical problems. Can you do exercises to strengthen your bladder? Definitely. So we talked about core strengthening being really important, keeping a healthy weight and doing Kegels, and then talking about seeing a pelvic floor physical therapist if you need it for teaching those better. So is bladder mesh safe? So very small areas of a tape like a bladder sling are very safe for most patients and can cure things like stress incontinence. We want to make sure you quit smoking and follow recovery instructions for these. Bigger pieces of mesh may be placed for certain repairs, and your doctor would talk to you more about that and what risks might be involved with placement of bigger pieces of mesh in different locations. Can you make sexual intimacy more comfortable? Definitely, whether it's coconut oil or estrogen creams, making sure there's enough stimulation and foreplay, those are ways that you can make sexual function more comfortable, and certainly seeing us to talk about it more. Next slide, please. So maybe you have more questions about HRT or Premarin vaginal treatment. Maybe you are thinking the sling surgery would be perfect for me. Maybe you're like, I really am not understanding a word you're saying about these Kegels. I want to go see a pelvic floor physical therapist. Maybe the pessary sounds really interesting to you and you'd like to use that. Maybe you're like, I think I need a hysterectomy or one of these prolapse surgeries. Or maybe you just need your routine screening, your mammogram or a pap. Any of those questions, we're happy to see you in our office. This is the number. We also are happy to answer questions too, over the phone to kind of figure out what the next best step would be for you. But if you have any other questions, I'm going to get to all those now. I'll get to the last slide, which is this is my little daughter who will be a wise woman one day too, who's a current second grader here in town in York. I did get a couple questions. I can't see the chat box right now. Let me see if I get it open. Okay, nothing's in the chat. So I did get one question that I was going to answer as well that wasn't specifically related to the topic of the talk, but I would welcome any questions now. So just let me know. The question was about the impact of the COVID vaccine on menstrual cycles. And actually, many of us anecdotally noted this. I will say I'm among those people who when they got their vaccine, had some breakthrough bleeding on my contraceptive method. And indeed, this has now been studied. And when I got COVID myself about a month ago, I'm doing fine. I was vaccinated and boosted. My family was as well. We've completed our quarantine, and none of the children or my husband have gone crazy, so that's good. We had just mild symptoms, but when I got COVID as well, I also noticed these symptoms of a little odd breakthrough bleeding. Well, they did a study of many women, and they found indeed that due to the vaccination that can have some limited systemic side effects. The study showed that 40% of women who got the COVID vaccine or had COVID themselves, that was a separate arm of the study, that they had a change in their menstrual cycle. So they had breakthrough bleeding, they had a longer, heavier cycle, but that was limited and it went back to normal in all of the women in the study. So they looked at all different women who were on birth control, off birth control, long-acting methods, not on birth control methods at all. And they noticed that this was in 40% of women, no matter what the case was. And, why does this happen? The vaccine has systemic effects. So it's probably, causes an inflammation or an inflammatory process in your body, right? Because it's an immune stimulator. And so it can maybe change some of those repair mechanisms of the uterus itself. It may cause also a vaccine-induced thrombocytopenia, or your platelet level could get lower, and that may impact bleeding a little bit. So whether it's inflammation or inflammatory changes, or it's because of some, platelet short-term changes, that could be why menstrual periods could change for a short period of time. This doesn't impact fertility. Obviously, these vaccines haven't been around long enough to look at long-term fertility studies, but there's good extrapolated data from similar vaccines or from animal studies that show that there's no impact on fertility from having COVID vaccination. We do know that having a COVID infection does impact pregnancy in a negative way. Women are more likely to have a more severe infection, or more likely to be hospitalized if they're pregnant, if they get viral illnesses in general, because our immune system is weakened when we're pregnant. We're considered a bit immunocompromised when we're pregnant. So women who get COVID may get sicker than women who weren't. However, most women will still have mild symptoms, because most women are going to be younger reproductive age women, and those women are going to get milder symptoms in general. We, certainly know that having COVID infection can have potential impacts on pregnancy, and it may increase risk of miscarriage or stillbirth, the infection, not the vaccination. So those are reasons why we encourage vaccination, but it's certainly, up to a patient and if they would like to do that or not. So if there's other questions, please let me know and pop them in here. So I hope that answers the question both about COVID vaccination and then COVID in general related to menstrual cycles, reproductive health, and fertility. Okay, let's see. A couple of comments. Thank you. I found the bladder health information useful. I'm postmenopausal, hypothyroid. She said that this patient says that many of the things that I recommended for menopause symptoms can help with thyroid symptoms, and I agree. What's interesting is actually some female hormones have a similar structure, like biochemically to thyroid hormones. So they partially can react with receptors in our body. So that makes sense that maybe some of these dietary or health changes could help with both. Is there a relationship between loss of estrogen and thyroid function? Yes, they are related, and they may mirror each other. We do know that thyroid, higher doses of thyroid medication may impact bone health as well, or bone strength. So advice in general with dealing menopause and hypothyroidism. This is, something to talk to both me and to your primary care doc about, or your, primary care and your GYN. But yes, I like to make sure that patients are getting enough of their thyroid hormone, that we check your thyroid levels. There's going to be a little bit different scale of thyroid hormones for women who are at reproductive age than women who have gone beyond their reproductive years, of sort of our goal of your thyroid. That's one of those hormones when people say, should I have my hormones checked? A thyroid hormone actually is one where we do need to check the actual level, because we're treating the level, not just side effects. And then in menopause, yes, you may need adjustments to that, basically, long story short. So you may need to have your thyroid level may have been totally stable all until you hit perimenopause, menopause, and then you may need to adjust how much thyroid hormone you get, and you may need more. Oversitopy, had a hysterectomy. Do I need an annual checkup? Great question. So if your uterus is out, you should still come in for me or your primary care doctor to do a pelvic or bimanual exam. This is the part of the exam everybody loves, right? Where you put a hand or a finger inside the vagina and one on your belly and feel your pelvic organs, because we still want to feel your ovaries to make sure that those are normal. We don't have a great screening test for ovarian cancer. So this is one of the things that we do for screening to make sure that we feel that those organs are normal. If you've had both your uterus and your cervix out, and you've had your ovaries out, you don't need to keep getting pap smears, and you don't need a bimanual examination unless you had new symptoms like bleeding or irritation. But you still may want to check in with your gynecologist or your primary care doctor for just general women's health, maybe sexual health kind of conversation. And for all of these women, you guys need an annual breast exam by a provider, and also a referral for a mammogram annually. So Yes and no. If you don't have a cervix and you don't have a uterus and you didn't have precancerous cells in your cervix, then you don't need any more pap smears, but you may still need a bimanual exam or a pelvic exam if you have your ovaries there. And everybody needs their breasts checked annually. Recommendation for good source of information on Mediterranean diet, high estrogen plants. It's hard to filter through all that shows up on the internet. That's a really good question. I will look and I will try to get an email back to you guys for that. I will look. I don't know the perfect things for that. I'll tell you places that I trust to look at. Mayo Clinic has actually very nicely digestible information that's accurate for patients. I could Google it right now if we have enough time and see if Mayo Clinic's Mediterranean diet recommendations are good and make sense. Certainly, it's nothing that you need to buy. It's not gluten-free, and it doesn't need to be anything specific, just general recommendations. You don't need to buy a separate, different diet. I'm 69. Is it too late to use vaginal estrogen creams to make things more comfortable? I have a significant atrophy in the body. No, it is not too late. It's never too late, actually, to start vaginal estrogen creams. I have some patients who start as early as their 40s. I have other patients who start actually earlier. I have some patients who start after they had their babies, because when breastfeeding, our estrogen levels are really low, and so some women might need estrogen cream even when breastfeeding. So I have some girls in my 20s, even in their 20s, who are using it. So there's really not a too young, and I don't have too old either. I have some patients who maybe haven't had discomfort or haven't been sexually active, but have noticed their bladder has been giving them more trouble, or they've noticed some more dryness. And I will start those estrogen creams on patients, some of them even starting in their 70s or 80s. So nope, it's never too late to start it. Just we prescribe it. You use it every night for a couple weeks. Think about it like chapstick. You want to sort of treat heavily at first when it's actually chapped. And then when it gets better, then you just lighten up using it as you need it. Might be as little as once or twice a month, might be as much as a couple times a week. So nope, never too late. The last one is, will Kegel exercises be lifelong if helped initially? So it depends on the woman. So it's never going to be harmful to do Kegels. Some women will need to do more Kegels actually initially, especially if they maybe just had a baby or just had surgery or had been neglecting some core strength for a while. They may need to do more. Other women might find that they have benefit from the Kegels for a while, and then the Kegel benefit is not as much for them. Maybe we need to then do some pelvic floor physical therapy with those women, or we need to end up prescribing the estrogen cream to help it as well. So they will be helpful. Some patients, though, they're not going to be a cure. So if you've had incontinence for your whole life, or you've suddenly developed incontinence, it's a good idea to see one of us as a provider too, to see what level, if any, pelvic organ prolapse is present. Because for some patients, even if you did Kegels all day long, you're to the point of a pelvic organ prolapse where the Kegels, the pelvic muscles can't be repaired, even if you do them all day long. And you might need a pessary or a surgical treatment. The last question I have here is, I had a total hysterectomy at 48. I'm almost 70 now. I am currently on a 0.25 estrogen patch, so a really low dose estrogen patch, and it's a patch, so lowest risk of stroke for this patient. I'm still getting night sweats and hot flashes. Do I need to stop my patch? So I take this individual to the woman. I have patients who are 90 who are still on their estrogen patch. They want to be on it because either they feel better, maybe they had a bone thinning history and didn't tolerate other medications to help bone health, or they still are having hot flashes at 90. If you're still getting them and you notice the patch is working, as long as you're healthy otherwise, check in with your primary care doctor or check in with one of us that prescribes hormone replacement therapy. And if we find that medically you're doing well otherwise, yes, you could still continue. You may even need a slightly higher dose. It sounds like, if you're still having them. But then maybe we would talk about trying some of these other alternative therapies, the diet, the exercise, to help your hot flashes a little bit too. But no, you don't necessarily need to come off of it or stop your patch unless you're having other medical issues. Many women will only have hot flashes right at their transition, and there's other women who suffer with them forever. So it depends on the woman. If they're occasional and they're not impacting your life, it's okay. If you're having them all the time, I say don't suffer, treat them. So I hope that answers your question. Did anybody else have any other questions? Okay, hold on. Let's see. Do I need family history of breast cancer for that person. So, hormone replacement therapy has not been shown to increase risk of breast cancer in big studies. So I will reassure you by saying that certainly, you do need to follow up with your primary care doctor or your GYN for mammograms and breast exams, but using low dose estrogen patches does not increase risk of breast cancer. So let that reassure you. Oh, here we go. Mediterranean diet. Perfect. Whoever looked this up. I'm going to screen it. Okay, good. Yeah, this looks good. Opt for whole grains, fruits and veggies, healthy fats, olive oil, more seafood, wonderful, reduce red meat, some dairy, spices. Yep, perfect. That looks great. And that's a good general thing to follow. Thank you for doing that. Oh, here's another good one. Look at this. Okay, I'll look at the other one. Any other questions from anybody or from the moderators?
I don't see any others.
Okay. Well, I appreciate you guys. Come in and feel free to email any other questions you have. I'll put my email in the chat box. Sorry, I'm going over a minute here. And I appreciate you guys having your time and attention. And I hope that I made you laugh a little and that you enjoyed doing your Kegels on your lunch hour.
Okay. I believe that brings us to the close of our presentation today, and we're very excited that we had the opportunity for you to meet Dr. Hansen, at least virtually, and hope that you found her information to be enjoyable and educational. And we hope that you would keep an eye out in your email from us early next week, because we'll be offering rather the recording of the webinar in case you'd like to refer to it in the future, or even forward it to a friend who may find it helpful as well. And of course, we'd love for you to bookmark the York Hospital event page on our website, where you can check out future webinars that we'll be hosting. Our next one is scheduled for February 10th at noon, and will feature a panel discussion on how to build a resilient brain and body through good nutrition. But in the meantime, we thank you for coming today and hope that you enjoy the rest of your afternoon. Thanks, everyone.
Thanks, guys. It sounds like next week that you can ask them all about the Mediterranean diet.
Indeed.